Excellent. Well, while a few more guests are getting seated, I would like to first say welcome to Healthier Together. My name is Stephanie Posen. I'm the Director of Annual Giving and Special Programs here at Memorial Sloan Kettering Cancer Center, and we really thank you for being here. I would also like to say thank you for your generous support. Philanthropy is a sustaining force at MSK. The funds that you have supported us provide hard-to-find early-stage funding for our research teams to pursue their most promising and novel ideas. In tonight's program, we'll discuss two themes. The first one is cancer prevention, and the other is early detection, including precision prevention, which is the harnessing of genetic information to predict risk and to stop cancer in its earliest stages. We couldn't focus on these two themes at a better time. The contrast between what was known about cancer 15 years ago and what's known today is astounding. So tonight, we've invited a panel of MSK experts to share with you the transformational impact their work has on those living with cancer today and their families. So tonight's program will begin with an overview from Dr. Philip Kantoff. Dr. Kantoff is a medical oncologist and the chairman of the Department of Medicine. Dr. Kantoff oversees the clinical and research programs of nearly 400 faculty members, while also maintaining his own research and practice caring for men with prostate cancer. So please join me in giving a warm welcome to Dr. Kantoff, who will introduce the rest of the panel.
Thank you, Stephanie, and thank you all for coming tonight and for your interest, and especially for your contributions to Memorial Sloan Kettering. We could not do what we do without you. From the video that you saw, it displayed a lot of the work that we do here, which is devoted to patients with cancer in trying to cure them, prolong lives, improve quality of life. Tonight, we're going to focus on two different things. One is cancer prevention, and the other is early detection, areas that we think hold a lot of promise with regard to improving cure rates and preventing death from cancer. So the first thing I'd like to do is introduce our esteemed panel of experts. Please raise your hand when I call your name. Dr. Michael Berger is the Associate Director of the Marie-José and Henry Kravitz Center for Molecular Oncology. He's an expert in cancer genetics, computational biology, and DNA sequencing technology. Michael? Dr. Allan Halpern is the Chief of Dermatology and is an expert in early detection methods for melanoma. Dr. Halpern? Dr. Carol Lee is one of the senior breast radiologists at MSK. She was the Chief of Breast Radiology at Yale before coming to MSK. Dr. Lee? Dr. Pari Shah is one of the gastroenterologists on the GI service in the Department of Medicine. Dr. Shah? And Dr. Michael Walsh is a pediatric oncologist and an expert in clinical genetics. So before I get started, I just want to get everybody on the same page with regard to what we're talking about tonight and give you a little bit of an understanding of the development of cancer and where cancer prevention and early detection lies in the spectrum of this disease. Okay, some basic principles of cancer. So there's a lot of confusion about genetics and cancer, and I just want to explain that in a little bit of detail. So part of the genetics of cancer is the germline, or the genetic blueprint, that which we inherit from our parents. So there are some rare cancers that are caused by the inheritance of a mutated gene. For example, the retinoblastoma gene gives rise to a rare disease called retinoblastoma. Then there are some common cancers that are caused by rare mutations in a gene. Examples, and something we'll be talking about, are BRCA1 and BRCA2, giving rise to breast and ovarian cancer. And there are many cancers that have a strong germline or hereditary predisposition caused by common variations in genes that each confer a very mild predisposition to cancer. So you hear expressions like there's a strong genetic component to breast cancer, yet only maybe 5% of breast cancers can be attributable to a gene that, if inherited, gives rise to a high likelihood of developing breast cancer, and the rest of the genetic component is this sea of more common but less impactful genes that are called variants in the genome. And we'll talk a little bit about that as well. Some other principles. Most cancers develop as a consequence of mutations in cells that occur after birth. So we first talked about germline abnormalities, hereditary predisposition to cancer. Now we're talking about what happens in the cancer cell. The cancer cell develops. The cancer cell develops presumably as a result of mutations in DNA that presumably occur randomly as a result of an error as the cell divides and is a failure of the process of DNA repair to work properly. So constantly cells are dividing, DNA is replicating or dividing, there are errors that occur at some frequency, and we have inherent biological properties that repair the DNA when working properly. Most mutations, and Dr. Berger and Dr. Walsh can speak to this, most mutations seem to be of no consequence. So they're happening all the time. You can find them, but they are probably of no consequence. Some mutations result in a growth advantage to the cell, and that is what promotes cancer. As mutations accumulate in cells, the cell may divide and grow and become a precancer and ultimately a cancer. So I'm going to show you a cartoon now that sort of summarizes all of this that I just talked about. So presumably it all starts in the form of a fertilized egg. And if we're lucky, we grow up to be a human being, and a healthy human being. Now, what occurs is a cell somewhere develops a mutation, and that's shown over here, and this mutation can promote the more rapid growth of the cell, and ultimately, as more mutations occur in the cell, there appears to be disorderly growth in the form of what's called dysplasia, and ultimately, as more accumulations accumulate, something that's called precancerous lesion is detected. The technical expression for this is in situ cancer, but ultimately a full cancer has invasive properties and the ability to spread elsewhere. So there are means of protecting us from cancer or reducing the risk of developing cancer, and that is, first of all, having an intact DNA repair mechanism, very important. And the other, as we're appreciating more and more, is having a robust immune system, because cancer cells develop and the immune system is out there recognizing cancer cells and taking them out of the system. So cancer partly is as a result of the immune system and its inability to take out the cancer cells that have been created. So one of the big things in immuno-oncology is to try to beef up the immune system to take advantage of the inherent immune system that we already have. On the flip side of this are the cancer-promoting events, and these include, as I said before, germline inherited cancer susceptibility genes. So these are there and give us variable probabilities developing different types of cancer. Smoking, of course. UV light, as we'll hear about from Dr. Halpern, is also an inciting event toward cancers. Certain viruses. Defects in DNA repair. So people can develop mutations in the DNA repair mechanisms that promote the development of cancer more rapidly. So let's start off with a discussion of prevention. And so without a doubt, smoking cessation is critical for the reduction of certain cancers, including lung cancer and bladder cancer and probably multiple other cancers. There are viral vaccines, such as the HPV vaccine, that reduces the risk of cervical cancer and penile cancer. There's treatment of hepatitis C, which is rampant, very common, and the treatment of hepatitis C probably reduces the risk of cirrhosis and probably reduces the risk of liver cancer as well. So let's turn to the panel. Dr. Halpern, I'm going to pick on you first, okay? So we're in a situation where we know that vitamin D is very important. It's a health-promoting vitamin. We call it a vitamin, but it's probably not a vitamin. It's actually a steroid. It has health-promoting activities, good for bones, good for good health. On the other hand, sunlight, which is required for the conversion of inactive to active vitamin D, is something that has deleterious effects. So can you give us some advice about this paradox? How do we get enough vitamin D, but also protect us from the development of the deleterious effects of UV light, sunlight, and the development of skin cancer?
So in order to put that question in perspective, the first thing you need to understand is why skin cancer is a big deal. And it turns out it's a big deal because it's so common, with almost 5 million cases a year in the US, that the majority of us in this room will get a skin cancer in our lifetime. And as Dr. Kantoff was explaining, one of the ways that cancer happens is cells get mutated, and there are certain things that, above the random mutations that he was talking about, can actually cause cells to have these mutations, and sunlight is one of them. As one of my patients likes to remind me, the sun up there is one big nuclear reaction that we're being exposed to, right? And so the question is, how do we avoid being one of those statistics who gets skin cancer? And it turns out almost 90% of skin cancers are related to sun exposure. Now, I don't want you to get the wrong take-home message that as a result, you can ignore spots on your body in places where the sun never shines, because it turns out you can also get skin cancer in those places. But 90% of skin cancers are related to sun exposure. And so how can we avoid getting skin cancer in the first place? It's really pretty simple. If we can protect ourselves from UV exposure, we can have a dramatic impact on reducing skin cancer. But there are some benefits to being in the sun. And actually, I'll come back to vitamin D, but I don't think it's the most important one. I think the most important one is just spending time outside. Mm-hmm. And because being outside is great for us psychologically, it's great when we do exercise and things like that outside. And so the question is, how do we enjoy the things we do and still not get a dose of skin cancer? And it means never lying in the sun, never working on a tan, trying to avoid a burn. Keep the hat on, keep the shirt on, wear a number 30 or higher sunscreen, and you could do these things outside. If you are protecting yourself, but you're still spending a fair amount of time outside, and you have a healthy diet, you probably still have enough vitamin D. But if you're not getting enough vitamin D because you're being that good about sun protection, you don't have milk or fish in your diet, you can take vitamin D as a very small supplement, and it's amazingly inexpensive and effective. And as that patient was also quick to remind an audience in one of these sort of settings, if you get a chance to take your vitamin D with a dose of skin cancer or without a dose of skin cancer, which one do you think you would choose?
Good. Just for my own edification, the SPF 30, 50, what does it all mean? What should I be getting? Should I be getting the 50, the 30, the 100?
That's a great question we could spend a lot of time on. The reason I said 30 is because it turns out if you read the official recommendations, it's supposed to be 15 or higher, and that's because that's going to block 90% of the rays, 97% of the rays actually, which should do pretty good. The problem is that assumes you use enough sunscreen, which means that you would go through an entire bottle of sunscreen in one weekend, because you're supposed to put on an ounce every 2 hours. For some of us, that bottle of sunscreen can last 2 seasons, right? So it turns out by going up to a 30, you end up getting a little bit more protection even when you don't apply sunscreen quite the way you'd like to. No real harm in going above that, but chances are 30 would suffice.
You know, sunscreen is dated, and I just noticed some bottles in my home that are in the 1990s. So I need to refresh. So I'm going to turn to Dr. Shah for a second here and ask her a question about colon cancer. And there's a fine line here, which I'm going to come back to, between prevention and early detection. And can you give us sort of an overview of prevention strategies as you see it for colon cancer?
Yes, so colon cancer prevention and colon cancer early detection are really best addressed by colonoscopy. Now, colon cancer also is quite important, as Dr. Halpern probably mentioned with skin cancer. It is the second most common cause of cancer-related death in men and women in the United States. So it is a common cancer, and colon cancer can be prevented. At Memorial, we conducted the study that showed, the National Polyp study, that showed that colon cancer screening, when initiated at the age of 50 and followed with guidelines, we can reduce the risk of colon cancer by identifying early precancerous lesions that follow the same pathway that we just discussed, that can be removed through colonoscopy and can help prevent colon cancer from developing. So colon cancer screening through colonoscopy is highly effective at prevention and early detection. Other ways to prevent colon cancer are ongoing and being studied. Recent studies have also shown that maybe aspirin use or NSAID use may also be preventative or reduce the risk of developing colon cancer, and as many as 20 to 40% of people, depending on the dose and how long the medication has been taken. So there are other things that people can do to help prevent colon cancer, but by and far, following the guidelines and having your colonoscopy starting at the age of 50 is really excellent.
When should screening begin? How frequently? When should it cease?
Good. So our guidelines suggest that in the United States, all adults starting at the age of 50 should begin colon cancer screening. There are a number of ways in which to be screened for colon cancer. Our gold standard is colonoscopy, and we recommend colonoscopy in all adults starting at the age of 50 and once every 10 years after that. We do make some adjustments to that recommendation based on what we find during your colonoscopy and your risk for colon cancer, which can be influenced by your family history and other genetic predispositions.
Okay, Dr. Lee, our breast cancer expert. Let's just talk about prevention now a little bit, and what do we know about breast cancer prevention?
Wouldn't it be wonderful if we could prevent breast cancer? I doubt there's a single person in this room who hasn't been touched by this disease in one way or another, a relative or a personal history, a friend, a neighbor, a colleague. Unfortunately, except for women who are identified as being at extremely high risk, such as those who are known to carry the BRCA mutation, or women who've had a previous biopsy that shows they have these atypical cells that are perhaps precancerous, there isn't much that can be done in terms of prevention. There are drugs that are given to women who've been identified at high risk, or some women who are known to be mutation carriers actually elect to have mastectomies to prevent the onset of breast cancer. But these are drastic measures that, as I said, are reserved for women who are at very high risk. For the average woman, there's very little. There's some evidence that not taking hormone replacement therapy after menopause may decrease the risk. There is an association between alcohol consumption and breast cancer. But other than that, maintaining a healthy lifestyle with maintaining an ideal body weight, getting exercise, eating healthy foods, just generally good medical advice also pertains to breast cancer. So in terms of the average person, I think with regard to breast cancer, early detection really is our best tool to preventing deaths from breast cancer, since we don't know really how to prevent the disease itself. And in terms of, I may be overstepping, but the recommendation is, at Memorial, we recommend that women start getting mammograms every year, beginning at age 40. And these are women at average risk, beginning at age 40, and then continuing as long as the woman is in good health. So if a woman has a life expectancy of 5 to 7 years, then it seems to make sense to continue having mammograms. There's not one age where a woman is automatically too old to have a mammogram. By the same token, if you have a younger woman, a woman in her 40s or 50s even, who has a lot of severe, serious medical conditions, then it may not make sense for her to have a screening mammogram. But mammography is the only tool that has been shown to decrease deaths from breast cancer.
So I want to make thank you very much for that. I want to make a distinction between prevention and early detection. I'll show a slide on that in a second. So prevention is preventing a cancer from occurring, and early detection is detecting a cancer that has developed early enough that you can make a difference in terms of the patient's outcome. So in this case, I think what Dr. Lee is saying, there really isn't anything yet developed for prevention, but in terms of early detection, we have some pretty good methods, and we're going to come back to different methods on the second time around.
And mammography does sometimes pick up these atypical cases.
Pre-malignant lesions.
Pre-malignant lesions that then we can treat, and in that respect, prevent. But that's
Right, so that line
Yeah.
between prevention and early detection is a little blurred, and we'll come back to that in a second. So I'm going to turn over to Dr. Walsh, one of our genetics experts. He's a pediatrician, and talk to Dr. Walsh about the germline risk factors. Those are the ones that you inherit. Can you talk a little bit about germline risk, and talk a little about the strong cancer susceptibility genes such as BRCA1, BRCA2, and what are your recommendations in terms of those who carry these high penetrance genes? And also speak more broadly about the frequency in the population, the general population, and in a cancer population of having those types of genes. So these are hereditary genes, not the cancer genes that develop in the cell that is developing into a cancer.
Sure. So thanks for the question. And you gave a very nice introduction in the beginning about the different types of changes that can occur in genes that we're born with. So in thinking about some of the gene changes that we think about predisposing or leading a person to be susceptible to cancer, we put genes into three broad categories: into highly penetrant cancer genes, moderately penetrant cancer genes.
What do you mean by penetrant?
Penetrant means whether or not you'll develop a cancer or not. So the light switch is on or off. So for BRCA1 and BRCA2, for instance, an individual that's born with a harmful, deleterious, pathogenic, those are all words for the same thing, change in the BRCA gene, a woman's lifetime risk up to the age of 80 is around 70%. Her lifetime risk of developing an ovarian cancer is on the order of 20 to 40%. For men, there's increased risks of prostate cancer, which is double compared to the general population. There's also an increased risk for pancreatic cancer. So BRCA1 and BRCA2 are originally described around breast cancer, but over the last 20 years, we've learned that there are a lot of other cancers that people are predisposed to when they have harmful mutations in these genes. And as a pediatric oncologist, we're seeing children with these mutations in their germline as well. Now, whether or not they're related to their cancer is an active area of research, but it has allowed us to intercept disease in their parents when we've gone and tested their mothers in a couple of instances where we've been able to make recommendations for risk reduction. In terms of what we recommend, when we identify an individual with a pathogenic or harmful BRCA mutation, for women, we make recommendations that they should begin MRI at the age of 25. Some women do elect to have a risk-reductive surgery. The risk never goes completely to zero, as there's always the possibility of a cell being left behind. For ovarian care, where we don't have a screening modality that we have confidence in, we do make a categorical recommendation at this time that women should have their ovaries removed around the age of 40. There are some slight differences between BRCA1 and BRCA2 in terms of overall lifetime risk, but that's something that, because those cancers can develop quickly and we've missed cancers through screening programs, that's a recommendation that we categorically make. For men with at risk for prostate cancer, we make recommendations that they should be linked in and begin their screening around the age of 45, having biomarker testing and a dedicated prostate exam.
You brought up prostate, and I can't help myself but say something about prostate.
Of course.
And talk about prevention methods in prostate cancer. People have tried for 20, 30 years to develop methods of or drugs to prevent prostate cancer, and there are large clinical trials testing out whether antioxidants like selenium and vitamin E might prevent prostate cancer, and that's unfortunately a flat negative. They do not. In fact, vitamin E in the large trial actually increased the incidence of prostate cancer. So vitamin E is not recommended. Selenium does not seem to do anything with regard to the development of prostate cancer. And there are a couple of very large clinical trials testing out a group of drugs called 5-alpha reductase inhibitors, which are drugs that block the conversion of testosterone to dihydrotestosterone, where dihydrotestosterone is the more potent androgen or testosterone version. These are drugs like Proscar, you may have heard of. Men might have heard of them. They help men who have difficulty urinating. The other one is dutasteride. So those two drugs were tested to try to prevent the development of prostate cancer. They did. They reduced the detection of prostate cancer by about 20 to 25%. But the paradox here is that the people who developed prostate cancer who were taking Proscar or dutasteride had a higher risk of developing higher grade prostate cancer. So it went to the FDA and they decided not to approve these drugs for the prevention of prostate cancer. So at the moment, we're like in breast cancer, we're saying healthy diet, exercise, do those heart healthy things to prevent prostate cancer. So I want to make this distinction between prevention and early detection. So prevention can occur, we talked about prevention, but it can occur anywhere in the spectrum from birth, let's say, until somewhere around here, when the cancer cell may have developed, it may be growing a little bit more rapidly, it may be growing abnormally, but before it's developed into a full-blown cancer. If you can detect it at that stage, then that's the point that you can treat it and cure it. That's what we're looking for. Now, early detection is in this gray zone between maybe those pre-malignant lesions, maybe those abnormal cells, all the way to an invasive cancer before it has metastasized or spread. So now we're going to talk about early detection. We've touched on it a little bit, and turn back to Dr. Halpern, and let's focus a little bit on some of the things that you're doing and some of the innovative things that MSK is doing with regard to early detection of melanoma.
Great. So, skin cancer is, again,
Microphone.
a little bit different in terms of early detection, in that skin cancer happens right on the surface of the skin where anyone can see it. So it turns out the majority of early detection in skin cancer is by people themselves being aware and paying close attention. So we never want to miss the teachable moment. So it's important that you know, for the more common skin cancers called basal and squamous cell, what you really want to make sure is if you have a pink spot that doesn't go away or keeps coming back in the same place or is easily irritated, go get it checked out. When it comes to melanoma, which is the deadly form of skin cancer, then the thing to look for is any dark spot that's changing color, shape, or size. And that's where I'm glad to say our group has had some, I think, big impact in the field. And I think it's a great example for tonight's meeting in that each of the things that I'm about to describe to you were initiated with philanthropic funding. And they've gone on to be able to be further leverage NIH funding and now industry partnerships, but none of them would have happened without significant philanthropic seed money. The first one that we were pioneers to do is, it wasn't rocket science. If change is really important, how do you know if something's changed if you don't know what it used to look like? And so years ago, we started taking pictures of people and using those pictures when they came back as a way to monitor to see whether or not their spots were changing. Now, this is not for every single person, but for people who are at increased risk for melanoma because they have a family history or personal history, or they've got a lot of moles, or they've got funny-looking moles, this is a real game changer. Well, what we've developed in the recent years, and only recently has been commercialized, is total body 3D imaging, where we can literally put people into a device, uses 96 cameras, takes a instantaneous picture of the whole body that can be used in 3D to track their moles. One of the other things that we've been developing in our group and take the lead on is something, it's got a fancy name, it's called Reflectance Confocal Microscopy. Basically, it's a device that you can literally put on the skin and see into the skin at the level of individual cells. And so that's beginning to bear some fruit as something that we can hopefully use once we've spotted something that's concerning to avoid a lot of unnecessary biopsies and also to direct the way that we remove especially big melanomas. And the third project that was also funded initially with philanthropy is something that we started a mere 3.5, 4 years ago called the International Skin Imaging Collaboration. And this is actually engaging melanoma centers around the world in a program to work with computer scientists to leverage artificial intelligence so that hopefully you'll get to the point where you'll have an app that really can be helpful in triaging lesions, that can help non-physicians or generalist physicians do a better job of knowing who to send to the dermatologist in order to catch those cancers as early as possible and hopefully avoid a lot of unnecessary biopsies along the way.
I must say that 3D program is really cool. I'm just concerned that I don't want to really engage in that whole thing myself personally.
Very few people love their personal naked 3D images, I've got to tell you. Right. But people are lining up because it's amazing
great, yeah.
how the patients understand the inherent value.
Right. Okay, Dr. Lee, breast cancer once again. Can you give us the standards with regard to your recommendations for standard mammography and then take it to the next level? Talk about all the other types of technologies that are being developed, including MRI, et cetera, and what your recommendations are. When are each of these technologies appropriate?
That's a great question. So for mammography, as I said, there is some disagreement among different medical societies as to when mammography should start, how often it should be done, and when it should stop. But basically, the recommendation from Memorial Sloan Kettering, from the National Comprehensive Cancer Center, and other organizations is to start having a mammogram at age 40 and have it every year and continue as long as you're in good health. Now, there are other ways of picking up breast cancer at an early stage, and all of these other methods are meant to be used in addition to mammography because each one will find something that the other won't. But the most common additional test is ultrasound, sonography, and this is particularly good for women who have dense breast tissue. Now, we're in the breast imaging community, we're becoming more and more aware of the significance of dense tissue. There are no two breasts that are exactly alike. I say they're like snowflakes. Each one is slightly different from the other. And some women have very dense tissue. That's a lot of white tissue that shows up in the mammogram. And in those cases, it's easy for a cancer to hide on a mammogram. ultrasound is very good at looking through that dense tissue and picking up cancers that might otherwise not be found. So there's a lot of work going on with ultrasound and its use in women with dense breasts. Another relatively recent development is 3D mammography. It's called tomosynthesis, and it's something that we offer at Memorial. And it seems to, the main value of the 3D mammogram is in decreasing the number of false alarms, because what it does is, by looking 3D and not having things kind of overlapping on themselves, you're able to not raise an alarm so much. It also has been shown to find more cancers than a standard mammogram, and it's becoming more and more utilized. Then there are other things like magnetic resonance imaging, MRI, which is a very powerful tool for picking up breast cancer. It's probably the most sensitive way, but there are some drawbacks to MRI. It's very expensive, it's uncomfortable, and it requires that you have an IV and dye injected intravenously to have. So it's really been reserved for women who are at very high risk, such as mutation carriers. We at Memorial, and again, in large part, this was started through philanthropic donations, we have been at the forefront in this country in defining screening mammography for high risk, screening MRI for high risk women, and probably do more high risk screening examinations here than any other facility in the country. What is exciting to me, and another thing that we're working on here, is doing an abbreviated MRI protocol, a shortened, less expensive MRI for average risk women, and adding that to mammography maybe once every 3 years, and in that way picking up cancers that the mammogram might have missed in a relatively cost-effective, more affordable way than has been the case in the past. Another thing that we have worked on at Memorial, and actually our early pilot studies helped get this technology FDA approved a few years ago, and it's called contrast mammography. It's not as widespread yet as, certainly not as tomography, sonography or MRI or tomosynthesis. But I think it's something that holds promise for the future. And what this is it's a mammogram that's done at 2 different exposures, and it's all physics that I don't really quite understand. But we inject an X-ray dye, and we take 2 mammograms, and then we subtract the first picture from the second picture, and we just get things that light up in the breast, often of which are cancers that we might not otherwise see. So this is all very promising technology, and it seems that I love my job, because it seems that every day there's something new, something exciting on the horizon that helps us, that will potentially help us to better detect breast cancer and potentially save more lives. And I suspect that in the next 10 years, how often we do mammography, who gets what test when, our understanding of that is going to improve. And we do here at Memorial have several studies that are comparing ultrasound, for example, to tomosynthesis, or the contrast mammogram to MRI. So we're doing quite a bit of very exciting work in this field to really pinpoint, to get to personalized screening, sort of not one size fits all.
I'll say that when I went to the website for breast imaging at MSK, there are about 10 to 15 people who spend all their time in breast imaging. Why would anybody want to go anywhere else? You know, when you have so many specialists, whereas in many centers you do general radiology as opposed to very specialized radiology on the breast. Dr. Shah, back to you. Sort of the innovations ahead of us in terms of early detection. What do you see?
There are a lot of good methods that we use in GI for early detection of GI cancers. So we talked a little bit about the role of colonoscopy in the early detection of colon cancer, and that remains the gold standard for colon cancer screening. But we also use other endoscopic tools to detect cancers or GI cancers in other areas. So in select groups of patients, we recommend screening tests for esophageal cancer using an upper endoscopy, which is a procedure that looks at the esophagus. In select patients at high risk, we consider cancer screening for gastric cancer with endoscopy. And within these technologies, we have a number of new methods that we're also using to try to identify areas that may be abnormal. Similar to what Dr. Halpern described, we use a type of confocal endomicroscopy to look at cells within the esophagus that could have abnormality, that may have changed from a normal cell to a precancerous cell or even further along the way. So there are a lot of new and innovative ways that we're using technology to identify cancer early, at a precancerous stage, or an early cancer stage, in all areas of the GI tract.
Great, thank you. So we're going to shift gears right now and talk about this area of precision prevention. Sounds really futuristic. And Dr. Berger, I'm going to give you some time to talk about what's meant by precision prevention and where are we going in this field.
Sure. I mean, I think at the heart of precision prevention is what we can learn from sequencing DNA, the DNA that's inherited, and acquired mutations in DNA that can lead to cancer. So I'm in the Department of Pathology, and pathology is a field of medicine that's been around for hundreds of years. And traditionally, pathologists have rendered a diagnosis by taking tumor tissue and looking at it under a microscope. So based on how the cells look and how big or small or dense they are, the pathologist can understand whether a cancer is aggressive or advanced, and that can have implications for how a patient might be treated. There's a new field in pathology called molecular diagnostics, where we can do similar things by taking molecules, specifically DNA, from cancerous cells, and apply modern DNA sequencing techniques to identify these mutations that also can have implications for the diagnosis of cancer and the prognosis of cancer, and more important, how a patient might respond to certain drugs. So I come at precision prevention from a slightly different angle. So in pathology, we do a lot of DNA sequencing of patients with advanced disease. So we sequence metastatic tumors often from patients with advanced cancers, and we use a test called MSK Impact. So this encompasses over 400 genes. It's one of the biggest sequencing tests that's been established anywhere, and we at Sloan Kettering have established the largest data set of its kind, having sequenced now over 20,000 patients over the last 3 or 4 years. And again, these are patients with advanced disease, and the main purpose is to find mutations that might predict whether these patients are going to respond to certain targeted therapies or immunotherapies, and you heard some of this already. And the way the test works is we're sequencing 2 samples of DNA from each patient. We're sequencing DNA from their tumor, and for comparison, we're sequencing DNA from healthy cells. And typically for patients with solid tumors like lung cancer, breast cancer, we use blood as a source of their germline or inherited genome. So we sequence cancerous cells and white blood cells, and we compare them. And that allows us to find which mutations are specific to the tumor, the acquired mutations. And these are really attractive drug targets, because if there's a certain targeted therapy that can selectively kill cancerous cells that have the mutation and spare healthy cells that don't, you can make major inroads in a patient's disease. But then, in the process, we accumulate data about the patient's inherited genome. So for patients with advanced cancer, they may not be interested in knowing if their cancer was a result of inherited mutations or somatic mutations. They're just dealing with their cancer at that time. But their children may care, and their grandchildren may care, and their siblings may care, and this type of sequencing may reveal opportunities to screen and potentially prevent cancer in relatives of advanced patients. And also in establishing this data, since we've now sequenced over 20,000 patients, we can probably, with more clarity than anyone else has been able to, establish associations between certain inherited mutations and certain types of cancer. So we can discover new inherited mutations that may be appropriate to screen for in future populations of patients. So this is part of the precision prevention initiative, is refining our screening guidelines, determining which people or which patients might benefit the most from this inherited testing, DNA testing, and sort of accumulate as much information as possible from all the patients that we've been sequencing. And I'll add at this point, this would not have been possible without philanthropic contributions. The development of MSK Impact relied heavily on philanthropy. The continued sequencing of patients relies extremely heavily on philanthropy until these sort of techniques become more standard in the field, and we might hope to get broader reimbursement from insurance companies. And the last thing I'll say right now, and we might talk a little bit more about techniques for early detection, but one thing that we realized from the MSK Impact sequencing was unexpected. So we sequenced tumor DNA and normal DNA, blood DNA, and we found mutations in the tumor that weren't in the blood. So we target those by drugs. We find mutations that are in both the tumor and the blood, and that reflects what's inherited from your mother or your father. But we also found mutations that were only in the blood cells and not in the tumor cells. And it turns out these are associated with a biological phenomenon. It's called clonal hematopoiesis. It's a technical term. But these are mutations that arise in blood cells in the genes that we know now are associated with leukemia. So these aren't patients that have leukemia, and it's not just restricted to patients with breast cancer or lung cancer. Healthy people have these mutations as well. But we're learning that these mutations can increase the risk of developing leukemias down the line. And based on some of these data that we've acquired and some of the research that's accompanying it, we're now establishing a new clinical division within within hematology for patients with clonal hematopoiesis detected unexpectedly in their blood that we sequence, where if they have certain mutations in certain genes and might be at greater risk for developing leukemias, they're referred to other doctors who can more closely monitor them and potentially prevent or detect earlier in the process these secondary malignancies of blood cells.
I'm going to push you a little bit back, and using next generation sequencing, just the technologies are getting cheaper, faster, higher resolution. Do you see sequencing moving back as a early detection methodology? And how far away from where we are right now do you see people going for blood tests and getting you have no evidence of cancer,
Right.
You have to worry about this cancer, go out and start worrying?
Right. So there are two ways that can happen. And again, everything I described up until now was sequencing DNA from cancer cells in patients who have advanced disease. So we're learning that certain people may be at greater risk for developing cancer because of inherited mutations that they inherited. Some of this may come from a strong family history and a history of cancer in their family, or even the detection of specific mutations through a relative's cancer that they had sequenced. I think Dr. Walsh can speak in greater detail of the screening guidelines and their efficacy and who might benefit the most from this type of screening. But that's one type of way sequencing can be used. It's looking at the DNA that you inherited in patients that might be at greater risk for cancer, and knowing that this person might want to get screened more early for colon cancer or breast cancer or so on. There's another method that also uses blood, but in a different way. So instead of sequencing DNA from blood cells, in the blood, you can actually capture freely floating DNA molecules in patients with cancer that were shed by tumor cells. So it's called circulating free DNA or circulating tumor DNA that can be extracted from a blood sample. We're using this routinely now for patients with advanced cancer, but it turns out even for patients with earlier stage cancer, with undiagnosed cancer, it can be possible to fish out and detect DNA molecules that look like they might have come from a cancer. And this has actually happened in a number of instances in a totally different field of non-invasive prenatal testing. So for women, it used to be women of an advanced age, but now many women who become pregnant can have non-invasive genetic testing performed to isolate freely floating DNA from the fetus. to look for chromosomal abnormalities, genetic deficiencies, Down syndrome, things like that. And over, the companies that did this type of testing sequenced hundreds of thousands of pregnant women, and there were a few dozen cases reported by these companies of not genetic abnormalities in the fetus, but genetic abnormalities indicative of cancer. So they weren't picking up fetal DNA, they were picking up tumor DNA in women with potentially ovarian or endometrial or uterine cancer that hadn't been diagnosed yet. So suggesting that this might be a path forward towards technologies to be used for early detection. Mm-hmm. This is still a little ways off. The concern with tests like this is it might lead to false positives where you're diagnosing cancer in someone that doesn't have cancer. And just as importantly, false negatives where the test isn't able to pick up an early growing tumor in a patient's blood. But it's something that we're working on a lot here, also heavily supported by philanthropy. And we're trying to be leaders in the technology development for these tests that can perform non-invasive cell-free DNA testing. It's also called a liquid biopsy. So you're familiar with the biopsy process where you can go, where a doctor would go in with a needle or even perform a surgery to isolate tissue that can then be sent to pathology and isolate, and DNA can be isolated and sequenced. The liquid biopsy is just a blood sample that can be drawn. And from that blood sample, we can isolate DNA from blood cells that represent the inherited genome and tumor DNA that's floating around that represent the cancer genome. We can run the same type of test in a much cheaper fashion, a much less invasive way.
So can I get my liquid biopsy now?
If you don't have cancer, there's really not proven that the sensitivity and the accuracy of the test are where they need to be. There are companies that are being developed around this premise. There's a big company called Grail, which we're partnering with here to assess the reliability of this type of testing. And it's actually spun out from the big DNA sequencing company called Illumina, which is where we buy all our instruments. So this company, Grail, has invested very heavily. They've raised funds from just about everybody to develop this type of test, which is their holy grail, the ability to detect cancer before it's been diagnosed. And I think we're still a few years away from that. And in the end, some of the applications for other clinical applications may be more fruitful, but it's something that we're definitely keeping an eye on.
So we only have a few minutes left, and I have some questions from the audience. I just want to run through a few of these quickly, quick answers, and then I apologize, but these folks will be ready afterwards to ask specific questions too. So I'm going to fire away. Dr. Shah, anything new in the early detection of pancreatic cancer?
So unfortunately, we do not yet have a screening test for pancreas cancer. And I am looking forward to the liquid biopsy to help with that. But in the interim, we do have a program here at Memorial that has been active for a number of years, looking at patients who are at high risk for pancreas cancer. So again, looking at patients with a BRCA mutation or with a strong family history of pancreas cancer, and trying to assess whether there are any imaging modalities which can be used for screening for pancreas cancer. So our study looks at using endoscopic ultrasound, which is an endoscopic technique to look at the pancreas, as well as MRI or MRCP, which are other imaging studies to look at the pancreas. So these are now being studied in patients that are high risk for pancreas cancer, not yet ready for a person who's at average risk for pancreas cancer, and we don't have a great screening test yet for that. We're still looking for that, something that we're actively working on here in our Pancreas Research Center.
Quick questions, Dr. Halpern. Family history for melanoma. Is there a genetic test for a hereditary predisposition to melanoma? If not, what do you recommend for people with strong family histories?
So interestingly, there is a genetic test for a significant percentage of patients with familial melanoma, and we don't use it very routinely because it turns out that what we would do to intervene is to get people to be better about sun protection and to check their skin. Mm-hmm. And that applies to most people, and the test is not perfectly sensitive or specific. And it actually does have an association with pancreatic cancer, which raises some other issues. Mm-hmm. For us, the interesting thing is we sort of wear our genetic predisposition to skin cancer on our skin. So without doing a test, by just knowing your skin color, your eye color, how easily you burn, how many moles you have, those are all reflections of your genetic predisposition to skin cancer. We're actually doing a study right now to find some more specific genes that might better tell us which of those patients go on to get cancer.
Okay, last question. I'm sorry, I'm running out of time. Dr. Walsh, if one child in a family gets cancer based on a specific genetic mutation, should the child's siblings and even cousins be tested for the mutation as a way to prevent cancer?
So the answer for the siblings is yes. There are situations where you can test the child and their parents aren't necessarily going to have the same mutation. They're what we call mosaics, the parents where you can find mutations in other children. So we do test siblings. Part of it depends, though, on the gene we're thinking about in the mutation. Regarding scenarios where we can prevent a cancer, there are a couple of situations related to thyroid cancer and colon cancer where we make recommendations for surgeries at an early age. For cousins, if the parents are negative with the testing, then we don't go on to test the cousins.
So I think we're going to have to wrap it up. I want to thank everybody for coming tonight, for your interest, and once again for your support of Memorial. I want to thank the panel and did a fantastic job. And now I'm going to hand it over to Stephanie.
Once again, thank you for participating. And our panelists will be here shortly after we dismiss this room. So the panel portion of this evening is concluded, but in just a moment, I'm going to invite you across the lobby. We have two wonderful breakout sessions. One is about healthy eating, so we're going to offer you some nutritious tips for the holidays. And then we also have a breakout session on the health benefits of yoga and meditation. So thank you again for joining us, and we will ask on your way out to spend 1 minute and fill out our survey. We want to continue to bring you programs that are helpful, informative, and get feedback from you. So thanks once again.